So the talk tonight that I was going to give is about dealing with multiple issues. So for people who have got addiction issues as well as other mental health issues, and what does that look like and how do you know the difference? And it was interesting because before I came here, I was in Paris with a dear friend of mine that we actually went to high school together. And so I've known him for 30 plus years. And he's been sober now 15 years, so we're talking. I just celebrated my 30-year sober last month. And we were talking, and one of the things that he said was that he is absolutely diagnosed bipolar, but that for the first 6 years of his recovery, he was absolutely miserable, and that at 6 years he was suicidal. And so here's a great example of someone who came into the program, worked hard, worked the steps, and really legitimately had a dual diagnosis. And that until it was treated, he wasn't able to flourish in recovery and enjoy life like he should. So my hope is that we're able to really help people self-identify when you need more, and also not try and make everybody in the world also have dual diagnosis issues too. One of the things that happens in the States is you can kind of tell what's sort of in vogue, because we'll have sort of the diagnosis du jour. So for a long time, I've worked in the field since 1982. So initially, when I came into the field, no one had anything except for addiction. And addiction was it, and you treated the addiction, and everything else was supposed to clear up. Then the SSRIs were developed, so then all of a sudden everybody was also depressed. So you came into treatment and you got off of everything, and then you were given Prozac was the big one. So everybody got Prozac and they were depressed. Well, then everybody was ADD or ADHD. Then everybody was bipolar. So now everybody's got a personality disorder back in the States. So again, how do you know if you really do or you don't? How do you know whether we don't want our clients to suffer. I mean, you get into recovery to have a better way of life. So we don't want people to suffer, but yet what is it, what's just not working a good program versus needing extra mental health treatment. So when you talk about mental health issues, they can go in 3 separate categories. The first category is what I call the cognitive category. It has to do with thought and how we're thinking. And in this category, we find people whose thoughts just aren't quite what everyone else's are. And this is where you have people that really are on a continuum, really not in reality. This is where you have schizophrenia. This is where you have delusional disorder. This is where you get bipolar type 1, where people, hello, I'm Jesus Christ, let me anoint you. Or one of the first clients I ever saw was Psychosis when I was back in graduate school. Scared me to death. I walked in and she said, I'm a mermaid, look at my fin, it's all flappy. And I thought, okay, I'm out of here. So again, not thinking clearly, psychotic. The next category is what we call the mood disorders, and that has to do with affect and my mood. And in there you get depression, anxiety disorders, and bipolar disorder type 2. And under anxiety disorders, again, you've got your obsessive compulsive disorder, you've got post-traumatic stress disorder. So again, things that affect my mood and how I am and my being with myself. So the first category, how it affects my thoughts. The second category of mental health diagnosis, it talks about my moods. And the third is relational. And the third has to do with how I interact and how I relate with people. And this is where you find your personality disorders. And in your personality disorders, we find people have a difficult time, and the way it manifests is with relationships. Relationships are very difficult. And for people with full-blown personality disorders, they're often, their relationships are very impaired. So, how do you know the difference? How do you know the difference between someone who's addicted and someone who's mentally ill, has mental health issues? What we know is that, and I've got a great slide for this, just not up right now, that we've got people who have mental health issues and people who've got addictions, and then we've got a crossover. And what the research shows is about 20% of the people who are addicted and have mental health issues also have both. Now, what we do know is that if a person's medicating their mental health issues with alcohol or drugs, you can't treat that mental health issue anyway until they get off the alcohol and drugs. And if someone's addicted and they also have, and vice versa. So you've got to, really sort things out. But it takes time. So we know that the part of the brain that's broken with addiction is the dopamine system, the older part of the brain and midbrain that controls survival. And what we know is that when a person's using drugs and alcohol, they're pushing that dopamine. And so the brain chemistry is absolutely shooken up. And so you've got to let people's brains calm down and settle down before people start to feel better and before you can really accurately come in and make a good diagnosis. A lot of things that look like mental health issues will clear up, but there's other stuff that just won't. And sometimes as diagnosticians, we're able to kind of have a feel for whether or not someone's got mental health issues by looking at the history, by looking at the symptoms that they're presenting with. I mean, there's some times where people are, again, with psychosis, it's often a little easier to tell the difference between the two because you'll have a history of it maybe without the drugs. But again, we also know that with the amphetamines and cocaine, we get drug-induced psychosis. So again, you've just got to give it some time. I broke down my talk into what I think are some of the common co-occurring disorders that we see. So it's on my PowerPoint, it's on my phone, so forgive me if I have to look down. But one of the first ones that I brought up was eating disorders, which again I think is also a process addiction, so it goes in the addiction category. But I just think it's very important, and I think it's something that a lot of people in recovery struggle with. Probably about 60% of all women who are alcoholic or drug addicted, and I use the two interchangeably, about 60% also suffer from an eating disorder. And in the reverse is true. And what we see a lot is that people who tend to have eating disorders also have a tendency to abuse alcohol. They have a tendency to abuse the stimulant drugs, partially because they keep your weight down, partially because they're attracted to that. They also have a tendency to use heroin because, again, that whole heroin chic look. So when women and men come into treatment, that's often something you have to look out for. Because often what you'll see is with men and women with food issues is they'll come into treatment, they'll get off the drugs and alcohol, and because they're squelching that part of the addiction, the eating disorder will begin to surge. So we'll see women purging in the bathrooms at treatment centers. Or we'll have people come into treatment and gain 20 or 30 pounds. And sometimes they need to gain some weight. But again, for a lot of people, that's a huge issue and has to be addressed. So a lot of people who come in have got all different kinds of food issues. And the food issues can be, again, from distorted body image, so they see themselves differently than they really are, to malnutrition, to bulimia, anorexia, compulsive overeating, exercise addiction. And again, I've seen this over and over again. Particularly, I can think of a case now, I've got a young woman who's a heroin addict, and she's also bulimic. And she will go and get off the heroin and detox, and then her eating disorder will begin to rage. And sooner than later, she'll go back on the heroin, and the eating disorder will start to, take off. The heroin takes off, the eating disorder subsides. So again, you've got to help people in recovery deal with both at the same time concurrently. With the personality disorders, again, these we often see come right out early on in early recovery too. Often in your treatment centers, you'll begin to see people have difficulty with relationships. And personality disorders, about 10 to 15% of the population has got a personality disorder. And again, that interacts, that impacts how we relate with each other. So the substances that you'll see people with personality disorders using are usually any and everything. The personality disorders are often, are now kind of clumped into three, what we call clusters. Do you guys do that over here? Talk about them in clusters? Cluster A, B, and C? Yes? No?
Not really.
Okay, okay. Well, what we've done over in the States, there were so many of them, is that they kind of took them and lumped them together.
Excuse me.
Freaking me out.
I thought I lost that earlier on.
Somebody doesn't like me talking about personality disorders. So there's cluster A, B, and C. And what they call in cluster A, these are kind of our odd or eccentric guys. This is the where you get paranoid personality disorder. You can get under that you can get sort of agoraphobia. You can get people who are more isolated, have a hard time interacting with other people, very avoidant. Cluster B is where you get your dramatic and emotional personality disorders. And that's probably the one you're most familiar with. That's where we have our antisocial personality disorder, our sociopaths. We've got our borderline personality disorder. We've got our histrionic personality disorder and our narcissistic personality disorder. And then with cluster C is our last one. That's sort of our anxious and fearful guys. So cluster A is more sort of socially off and not really able to make friends and connect with people, where cluster C is a personality style that's just very scared, very anxious, sometimes can be kind of dependent, sometimes can be sort of obsessive, compulsive. So I think the one that I think gets thrown around a lot are the personality disorders under cluster B, the dramatic, energetic ones. And what really happens with people who've got personality disorders, among other things, is that they have a lack of ability to regulate their own emotions. So where most of us are able to go, I'm okay, I'm a little miffed, now I'm feeling a little frustrated, now I'm getting angry, now I'm really mad, and now I've got blinding rage, right? We have gears there. People with personality disorders are often unable, they have no gears. So they'll go from 0 to 60 in a second. So, I broke a shoe, a shoelace, and I'm in a blinding rage. Like there's no ability to moderate or modulate their own emotions. And this comes out in relationships horribly. So part of what happens in treatment and helping people get better is to bring in types of therapy to help people do that, regulate their emotions, regulate them, regulate their feelings, and to often help people even learn how to relate in a proper way and have friendships. So this would be the kind of person who, is constantly firing their sponsor and getting a new one, or struggling in relationship after relationship. And again, some of the other qualities, like when you've got the narcissistic piece in there, it makes it flat out impossible for a person to see their impact on others. So it makes it impossible for them to have that empathetic piece and say, oh, this is how that impacted you. That must have really been hurtful, or that must have really scared you. They're not able to do that, put themselves in your shoes. So again, it's a very dysfunctional way or hurtful way of relating to people. Often with personality disorders, some of the red flags of whether a person may or may not have one, you'll often get self-harm in there, so you may get cutting. You may also get other types of self-harm or explosiveness, fists in the wall, breaking important things. I had a client once that was a physician and in recovery, and she also had a lot of trauma issues and struggled with a personality disorder. And one of the ways that she self-harmed was she would take so much Advil or ibuprofen every day that it would eat the lining of her stomach, so that she constantly had that pain. So sometimes it's much more, it's not outward. I probably worked with one of the most difficult borderline personality disorders I've ever worked with recently. And if I'm saying that, I've probably done about 2,000 interventions. So if I'm saying the bar was up there. And she was emotional. She was combative. She came into my office. People would try, her parents would try and talk. She spit on my floor, called me dog. Just absolutely, offensive. And then in the next minute, saying to her parents, well, if you'll just give me this or give me that, left, cut herself all up. Just all over the map with trying to, manage her own emotions. So, again, those are a lot of signs that you can see. Is if you're also seeing self-harm, you always want to rule out whether there's trauma there and whether or not you're looking at a personality disorder. And sometimes people in recovery will keep that. That'll be one of their big secrets, is that they're self-harming and they don't feel comfortable telling their sponsor about it or talking about it. Does that make sense? Okay. So I can talk a little bit about, with the mood disorders. Again, you get, under that you get depression and you get your bipolar. Do you guys take bipolar and divide it in bipolar 1 and bipolar 2? Okay. Okay. So that's where you'd really find your bipolar 2, where you wouldn't necessarily have the mania with the psychosis. And I think that, again, it's important to, particularly before giving someone the bipolar diagnosis, to really let their brain chemistry settle. But then once somebody has, been in therapy, been in programs, going to their 12-step meetings, and you're at a year and they're not feeling any relief or any better and feeling miserable, is when I really think, and maybe sooner, depending on how miserable they're feeling, is when you really have to come in and look at, do you have a true biochemical imbalance, a major depression, or a true bipolar disorder. Often, I think the other thing we see a lot of is the anxiety disorders. With depression, people tend to use a lot of alcohol. You see people tend to use, for whatever reason, a lot of benzodiazepines like Xanax and Valium. With anxiety disorders, you often see people do the same thing, to use the alcohol and the benzos to try and take the edge off of themselves. Anxiety is fear. Anxiety is being wound up and having fear inside that just doesn't want to, go. And it comes and goes in surges. One thing about anxiety is that it never just stays the same. Depression will stay the same, and feel absolutely never ending. But with anxiety, it always comes and goes in waves. And often for people, they'll have huge flat-out anxiety attacks, where your heart's beating, you can't be in a place, you can't breathe. And when I was in graduate school, we probably learned about 150, at least, non-chemical techniques to treat anxiety. And that was in the early 80s. And what happened to healthcare back in the States about the mid-80s was that a new model was introduced called managed care. And what managed care did is they came in and said, gee, you can go see this counselor 15 times and learn a technique to take care of your anxiety that, is effective, but we have to pay for 15 sessions to do it. Or you can go to the psychiatrist over here and he can give you a Valium or a Xanax or a benzodiazepine, and that'll take care of it, and he can do it in 15 minutes, and we pay for one appointment. So what happened in psychology is that teaching people how to deal with anxiety in non-chemical ways went to the wayside. And that's why we have so many people addicted to prescription pills, particularly for the anxiety disorders. So part of helping people, people will, anxiety feels like you're going to die. You're not, but it feels like you're going to. So often people in early recovery, if you can get them to a place and help them really learn how to deal with their anxiety, half of it, 50%, is helping them breathe. Because when you get scared, you go, right, and hold your breath. Well, then you hold your breath, you're not really breathing, then what happens? You start to get a little dizzy. You start to get a little dizzy, you start to get a little panicky because I'm getting a little dizzy, now I'm starting to sweat. Now I'm really starting to freak. Now I'm starting to hear myself think, and it goes and it builds, and the next thing you know, you're having a full-blown anxiety attack. In 12-step, we talk about using your self-talk, thinking things through, slowing yourself down. And all of that's really about, cognitive behavioral ways to treat your anxiety. So, and anxiety disorders, again, I went into a lot of detail over them, and if you have any questions, we can go. But I mean, again, you can get anxiety disorders with phobias, with panic disorders. I think the one that we are seeing the most of, I'll spend a couple minutes on. You get obsessive compulsive disorder. Do you guys have that show, The Hoarders?
It was on.
It was, yeah. There's a lot of people have become interested with OCD, and I'll tell you, some of the worst, most difficult interventions I've done have been OCD with hoarding. I mean, the time I literally almost got punched in the face was with a client who had OCD. And again, obsessions are things that go through people's heads over and over again, like did I turn off the lights, did I feed the dog, did I lock the door? Compulsions are rituals that people need to act out and go through, so they're different. So I had a client in California, and the family called me up and they said, well, our son is in trouble, he's got OCD, and his father had it too, but his dad's better now. And I said, well, tell me more, tell me about it. He said, well, he'll walk about 10 steps and then he has to dance a jig. And I thought, well, how hard can that be? I can dance a jig with him and we'll get wherever we need to go, right? So I get there. Well, he also has another ritual, which is an internalized ritual that has to do with his breath. So the way it looked on the outside, we're in the middle of having conversations, and all of a sudden, he just went catatonic for like 45 minutes. And that was part of his ritual. And what he was doing something ritualistic with his breath that nobody knew what it was. Now, after about 45 minutes and all my infinite wisdom, I decided we really needed to get the show rolling. So I reached over, don't ever do this, and touched him on the arm and said, Johnny. Well, you don't ever want to disrupt he flew up swinging, and literally. And I have a guy that travels with me sometimes when I do interventions who's about 6'4" and 220, and he caught the fist right there. I've never been so grateful to have him. But it's very, very difficult. So again, and often, and the whole family was impacted. Mom, when he would get in these frozen states, and he'd do it sometimes for hours, would literally come up with a spoon and open his mouth and put food in his mouth and pull the spoon out and chew it, for him. So the whole family was enmeshed and organized around his OCD. But the other one I wanted to talk about for a second is post-traumatic stress disorder, because we have so many vets coming back from Iraq and Afghanistan, and I know you do here too. And again, so PTSD is also is an anxiety disorder. And what we see with post-traumatic stress disorder, again, there's something traumatic has happened. Now, again, let me stop and say that trauma is all about perspective. Things are traumatic based on a person's perspective. You can have 3 family members in an automobile accident, and each of them will experience that differently. So one person's trauma may not be another's. So trauma is trauma because I say it's my trauma. And what may be traumatic for me may not be for you. But what happens with trauma is that it's really, with PTSD, there's really a whole survival mechanism about it that really dates back to when we first, were almost cavemen, which is, you're out and you run into that saber-toothed tiger, and all of a sudden fight or flight kicks in, and the fact that you can't, that you're scared, you can't react like you need to if you go into that fear place. So your brain has a beautiful way of taking all the fear and taking it and putting it in this little suitcase and packaging it in a different part of your brain so you can keep surviving and do what you need to do. And then when you get back to where you need to get and things get okay and you rest, then it may or may not pop back out because the storage system's pretty fragile. So when it pops back out, what you get is sometimes things will trigger the fear or the anger. Sometimes things will trigger body memories or body sensations. So people will have often, again, flashbacks of the trauma, what happened, nightmares, an inability to connect with people, depression. And people will re-experience trauma in different ways. Sometimes they may have the cognitive thought, they may have the thought and the picture that goes with it. But other times they may have none of that, and they may only have the physical experience, or the smell, or the auditory. So again, it can feel it can be very disruptive to people's lives. So again, that's something I think we're seeing a lot. And again, we also know that most people, some of our research is now showing 70 to 80% of all people in recovery in certain studies have had trauma, in their life, and have some symptoms of PTSD. So again, I think it's important to help people understand what it is, what it looks like, and how to treat it. The other stuff is that I spend a lot more time on every single topic that I talk about, so I don't know how much you'd like me to do, but the other thing is, do we talk for a minute about psychosis, thought disorders? Okay, all right. So a thought disorder, again, impacts my thinking and how I see the world. And part of what's very difficult about psychosis is that people who are experiencing it sometimes are aware that their thoughts are off, but often they aren't. And so sometimes they'll have moments. Paranoia is the worst. So people who think that they can't trust you, they're out to get you, you're trying to explain to them that something's wrong. And it can be very, very difficult to help. In this, a lot of my cases, I would say probably of all the clients that I work with that have psychotic disorders, probably about 80% of them don't have a whole lot of awareness and insight. About 20% do. Most of them have had breaks before, and so they've been educated about it and have a believability about it that, once they're back on their medication, that they're able to say, I understand now that I was psychotic, and here's what was happening. But about 80% of the cases that I work with don't. So again, it can be very difficult because you can also put it on a continuum. You've got everything from that sort of just odd thinking all the way down to then you've got like schizotypal, then you've got flat out schizophrenia or delusional disorder. So it can be definitely people have to be most often medicated to really be able to come back into reality so that they can learn about it. And often, in the States anyway, we end up having to utilize other systems, like often having to get legal medical power of attorney over someone or get them committed to be able to get them medicated. I've got several cases. One of the things I seem to be known for working with people with psychotic disorders, and I've got several cases right now. And again, I've got a young man in particular who part of his delusion is he's a musician, he's very grandiose, and his parents want so much to believe he's not sick that he will be leaving horrible messages on people's voicemails, or out getting in bar fights, and thinking that the house is bugged, so tearing everything up and throwing it out in the yard. And yet Mom said to me, we were talking about getting him some help one day, and again, he had left a threatening message on somebody's phone in the middle of the night, police were involved. And Mom said, I think he's really okay, put his dishes in the sink today. And I said, well, I don't really think putting dishes in your sink is really quite the test for Again, families get so wrapped up in wanting, it's very painful. I think part of what happens when you've got severe mental health issues is that the families have got such a sense of loss. At least with addiction, you get moments of hope. Like people get off drugs, they get better, and all of a sudden you feel like you've gotten your son or your daughter back. But with ongoing mental health, particularly psychosis, there's so much profound grieving to be done, because even when people are off drugs, they're not really there, and it's not really, okay, and it's such a chronic illness that everyone in the family needs extra help in helping hold those boundaries. And the difficulty with people who've got psychotic disorders and bipolar type 1, again, a lot of people will say to their addicts, if you don't get sober, if you don't get better, if you don't go get help, we're going to kick you out on the streets. And if you do that with somebody with a psychotic disorder, they'll just go live on the streets and be fine, because they're not able to really be in touch with when they're uncomfortable or not.